pediatric hernia, left inguinal hernia. So we are going to start with insufflation. The pressure will be around 10 to 12 millimeters of mercury, and patient is intubated. Patient has to pass urine before coming to OT so that there will not be any bladder distension. And normally we use 5 millimeter telescope for pediatric hernia, but here for demonstration purpose we are going to use 10 mm telescope, so that the anatomy can can be appreciated better. So this is the foot end of the patient, and this is the head end of the patient. So umbilicus is here. So normally we will go through the umbilicus, but here in this case I will go about 1 centimeter above the umbilicus, so that I can show in a better way the panoramic view of the inguinal hernia, inguinal anatomy. So this is a 15 blade knife and a Verus needle. So I am going to introduce the Verus needle and 15 blade knife. Verus needle, and I am going to insufflate. Now the pressure is 12 millimeters of mercury, and you can keep the flow rate at around 10 liters per minute. Since I am insufflating with Verus needle.
Sendhil, any precautions?
Yeah.
Depending based on the small status, body status,
yes,
pediatric patient, any special precautions you take?
Main thing is because of thin abdominal wall, avoid using 11 blade knife. You can use 15 blade knife. 11 is too sharp, and there are incidents of aortic puncture with the first nick itself. So those sort of any thin patient you should avoid using 15 blade knife, and you have to hold the Verus needle in a well relaxed abdomen. You have to hold the Verus needle very close to the tip, so that even if it enters suddenly, it won't hit the, only 1 centimeter should be unprotected. Are you able to see the hand?
Yes.
So you have to hold it like this, put it here and lift it nicely and insert it.
Controlled puncture.
Correct. So normally the teaching is to hold it like this. Verus needle should be held like this. That is the teaching. But in this case, you just keep your finger like this, so that there will not be any sudden entry to into the abdominal cavity. So normally I use 5 mm scope, but here I am going to use 10 mm.
And if you see, he is using his index finger to protect the abdominal wall, so that you will know at what level you have entered.
Here I don't want to press too much. I am making small incision here.
So sometimes what happens is the contour of the abdomen is very less. Sometimes you place a 5 mm and then go for 10 mm. So it's all your comfort level, that's all.
Patient should be relaxed well. And so actually I am standing on the left side of the patient. Now I am moving from the left side. So you can see it is bilateral hernia. Actually clinically it was a unilateral hernia, but here you can appreciate it is a bilateral hernia. So yeah, definitely it's better to infiltrate with the local anesthesia before making any incision. So now I am introducing a 5 mm trocar. There is a little bit of port side bleeding. I will just check it. So always you change the direction of the trocar. So even if it enters suddenly, it should not be directed towards the major vascular structures. This is the camera port is in the supra-umbilical area. It is normally we use 5 mm port, but for the demonstration purpose we are using 10 millimeter port. There is a little bit of port side bleed that will get control. Again I will check it.
The working ports generally you use a 5 mm or a 3 mm, sir?
Normally we use 5 mm, but 3 mm is also better. But we don't have that. We can buy 1 or 2 instruments and we can use it. But the 5 mm gives the suturing and all. I am very comfortable with 5 mm. Normally 5 millimeters we use for pediatric hernias. So 2 working ports I have placed. One is first is the camera port. Normally we place at the level of umbilicus. Here I have placed about a centimeter above the umbilicus, and 2 5 mm port almost at the level of the camera port. Right is at the right midclavicular line and left is at the left midclavicular line. You can see the setup.
Yes, sir. Perfect.
This is the monitor, and this is the foot end. and this is the camera port, which is just above the umbilicus, and there is a little bit of port side bleed from at the incision side bleed. Bilateral hernia, we are placing both the working ports at the same level.
Right, sir.
Right and left working port at the same level, about at a centimeter, 1 centimeter below the level of the camera port on either side.
Right, sir.
Somewhere in the mid clavicular line. So for right inguinal hernia, this will remain same. The right working port will remain same. The left port will come slightly medially and about a centimeter below also. Instead of here, we will have somewhere like here, about a centimeter below and a centimeter medially. So that the direction will be like this. We will be working like this. For left inguinal hernia, this will remain same. This will come a centimeter below and medially, so that we will be able to do work like this. So this is the left inguinal hernia, and this is a right inguinal hernia. Clinically, main advantage of laparoscopy is we can know whether it is really a unilateral or bilateral hernia. Clinically, it was a unilateral hernia, but in this case, after putting diagnostic laparoscopy, we are able to see hernia on both sides. So this is the placement of port, and normally 5 millimeter through the umbilicus and 5 millimeter on either side is the port what we use. But here, to get some panoramic view, I have placed the camera about a centimeter above the umbilicus. Is it okay?
Yes, sir.
Yeah.
And the pneumo you decide. How do you decide on the patients, and what is the pneumo?
Normally a patient below 10 years, I prefer to use around 10 to 12 millimeters of mercury. And adults 14. Normally we use around 14 millimeters. So normally less than 5 years, somewhere around 8 to 10 millimeters. From 5 years onwards till around 15 years, we can use around 10 to 12 also. So now you can see this is the content. You can appreciate the momentum which is going inside, and this is the you can appreciate the iliopubic tract here. This is the iliopubic tract. I am going to put a stitch, the iliopubic tract repair, and here you can see there is another hernia on the right side, and the patient is in nice head down tilt. Bladder is partially filled, and we can see the anatomy here. This is the inferior epigastric artery. The camera is striker 1688. This is the inferior epigastric artery. Lateral to the inferior epigastric artery, we have got the hernial defect. So this is the indirect inguinal hernia. You can appreciate normally there will not be any fold here. Usually the described is lateral inguinal ligament along the course of the inferior epigastric artery. Normally we don't see any fold. That is the lateral inguinal ligament. This is the medial ligament, and this is the median umbilical ligament. So median umbilical ligament is formed by the urachus in the midline, and if you go laterally, this is the medial umbilical ligament. This is the lateral umbilical ligament, and if you come down, you can appreciate the vessels. So this is the external iliac artery. If you go down here, this is the external iliac vein. The medial umbilical ligament, it is continuing here, and here if you come on the right side, this is medial umbilical ligament on the right side, and this is lateral umbilical. You can appreciate a small ligament here. This is formed by inferior epigastric vessel. This is the lateral umbilical ligament, and lateral to the inferior epigastric vessel, you have got the right indirect inguinal hernia. And if you come down, you can appreciate the nerves underneath. These are all the nerves which is going underneath. You have to be very careful. And this is the iliopubic tract. We can appreciate here that small white structure is the iliopubic tract. So this is the anatomy. This is triangle of doom. You can see the vast difference. The gonadal vessel. So this is the external iliac artery. And if you come down medially, you can see the external iliac vein. So this is a distended bladder. So this is the anatomy which we can appreciate.
Do you decide between an IPT or a straightforward hernia?
Previously, we are doing only herniatomy. We had 1 or 2 recurrences following this plain herniatomy. Then we started using this iliopubic tract repair. Just as it is nothing like putting a small, darning stitch, 1 or 2 stitches continuous loose stitch, just to give some support to the peritoneal closure. So that is actually this will have a support. If you put stitches by using a proline, this will give a support to the peritoneal closure. That is very loose and very few stitches. This is a AB diathermy I am using. So now I am making a small nick here.
It's in the peritoneum.
It is in the peritoneum alone. Carefully, see, first incision we have to avoid close to the vas deferens. So just go around the hernia.
So another layer which you can see near beside the peritoneum is the transversus fascia there.
Fascia transversalis.
Yeah, and one has to go above the fascia transversalis because fascia transversalis is again a bilamellar structure.
So we are just making a peritoneal incision. We are just disconnecting the sac. Very gentle, very careful dissection. So at the level of vas deferens and gonadal vessel, avoid using diathermy. There is some peritoneal fluid here. Now I will take this peritoneum carefully. I will remove all the structures, and whenever we are doing a dissection, avoid holding the vas deferens, avoid holding the touching the vas deferens. As Ashwin said, this 5 millimeter instrument looks too big for this structures. So just take out all these structures like this. See all the structures are moving away. This little bit of bleeding will get controlled. No need to worry about those oozes. It will get, by the time you finish the procedure, it will get controlled. Yeah, I'm going to completely disconnect the sac. Almost done. So you can see the peritoneum all around divided.
Yeah, we can appreciate it well, sir.
So basically disconnecting the sac completely.
Just to know the evolution, I think Sendhil,
Yeah.
in initial days, we used to take a stitch, proline stitch with
Yes.
the sac and came.
Yeah.
Then we saw little recurrences and little, fluid in the sac
Yes.
and all those things. I think this modification is all with the experience.
Yeah.
Now,
Actually, the results are very good.
results
Actually.
are very good. Yes.
Sendhil sir, we know that the course of the nerve is very close to the iliopubic tract.
Yeah.
So in these patients, when you do an iliopubic tract repair,
Mm-hmm.
is there any concern of a nerve entrapment and having a problem of chronic pain in these set of patients?
Yeah. Only thing that we should see that while taking bite, we have to be extremely careful. So actually, the needle course should be seen through the iliopubic tract. I will show the needle while passing. It should, you have to lift the structure. So this, you can see it is completely disconnected sac. The peritoneum all around is away. Are you able to see?
Yeah, we can appreciate it very well, sir.
I am going to introduce this 20 proline. You can appreciate I am pressing from above. So I am introducing this needle through percutaneously because this will go through 10 mm trocar, but normally we use 5 mm trocar. This needle is too big here.
And the patient's abdominal wall also is very small, so it's easily introduced, right?
Okay. So I am going to see, this is the conjoined muscle. Just go and make a small superficial bite.
Sendhil, which muscle you have taken?
This is a conjoined muscle, sir.
Conjoined.
Conjoined muscle, and you can appreciate the iliopubic tract here. So catch this iliopubic tract, lift it up like this, and put your needle, and see this entire course is seen. Are you able to see the tract?
I can appreciate it.
This is just to give some protection to the some support. This is not actually a repair. This is just a 1 or 2 stitches to support the. This is more like a fascia transversalis here. Yes. This will give a good support for the mesh. And here again, I am just taking, lifting it away nicely.
Dr. Sendhil, we are back with you.
Yeah, Ashwin.
Dr. Sendhil, please, we were watching you.
Yeah.
Show us.
This side, right side, we have disconnected the sac, and this needle is previously it was a 2-0 polypropylene. Now it is 3-0. It looks better slightly. See, take a more like a fascia rather than muscles. You just slide your needle. It is like fascia transversalis and little bit of conjoined muscle, and be careful. Just take this fascia and a bit of iliopubic tract here, nicely lift it, and then basically you have to be very careful. You can appreciate that you are seeing the entire course of the thread. Are you able to see the here?
We are able to appreciate it.
Close up.
No, we can see it very well.
Yeah. So like that, you have to lift and take very more like fascia transversalis and little bit of iliopubic tract. I mean, a little bit of conjoined muscles.
So how do you decide what is adequate narrowing for this patient, or generally in your practice when you do these?
It should be a very loose repair, and no need to go close to the vas difference at all. Basically, our idea is to give some support to the peritoneum. That's it. So we'll stop about 4-5 millimeter lateral to the vas difference. Gonadal vessels. See here, around 1 centimeter is there. So what I'll do, I'll just push this gently. I'll push this gonadal vessel like immediately, and I'll take one more bite here. I'll lift it nicely, and I'm taking extreme care while passing the needle, and I'm lifting the tissues while passing the needle, and I'm protecting the vas difference and the gonadal vessels, and I'm taking the bite here. So this is enough, more than enough. Then what I will do, I will go back with one more stitch so that while tightening there will not be any.
So Sendhil, Dr. Sendhil, using the proline, or rather preferring the proline over the vicryl,
Yes, sir.
is better?
Proline, yeah, proline I'm not going to do, I'm not going to tighten it. It is just like a darning, very loose stitch I am going to place. I'm not going to, it's not like a classical repair I'm doing darning, very loose darning just to support the the peritoneum, that's it.
So in addition to this suture, you had actually taken a purse ring and closed the peritoneum also.
Yeah, peritoneum
so
also.
Could you just, for the benefit of the delegates, tell why that is also important and only this is not?
Actually, that is the primary, herniatomy that should be done, and this is a secondary, additional step. Actually, that is the primary step to close the peritoneum. So this is an additional step just to have some protection to the repair. That's it. See, here you can see the needle entire passage is seen.
We are able to appreciate it well, sir.
Actually, this Maryland is better here because. So now I've gone back again. So are you able to appreciate? One stitch I have gone back again laterally, and the thread which is coming through the skin, we have divided it. Gently pulling it, I'll relax it again. See, gently pulling it like this. So it gives some, I'm not completely closing the defect.
I am reminded of the days when Sendhil was a postgraduate and I was assistant in pediatric surgery. We used to open the inguinal canal, just to isolate the sac, ligate the proximal sac, and leave behind the divided distal sac as such without closing. Still we practice it. And paradoxically, when there is a patent processus vaginalis on the contralateral side without symptomatic hernia, they all do not progress to symptomatic hernia. Some of them close spontaneously. But in a pediatric surgical laparoscopic surgery, we cannot afford to
leave
behind.
Yes, sir.
We will have to close it.
Yes, sir.
As Dr. Sendhil is practicing. doing it now.
Till what age you will be waiting for spontaneous closure, sir? Any
Inguinal hernia do not close spontaneously.
spontaneously? Okay, okay, sir.
Hydrocele,
Yes.
wait up to 1 to 2 years of age.
1 to 2 years. Okay, okay, sir. Umbilical?
Umbilical, when there is no history of obstruction,
Yes, sir.
wait for 3-4 years of age.
3-4.
Most of them close.
3 to
There is a history of obstruction.
Yes, sir.
It is very necessary that you should close it. Because inguinal hernias, when they get obstructed, most of the children escape.
Yes, sir. Yes,
They
sir.
report to us
Yes, sir.
and we are able to save the bowel also.
Yes, sir. Yes, sir.
But that is not the case with umbilical hernia.
Okay,
When
okay.
it gets obstructed,
Yes, sir.
sometimes it rapidly becomes gangrenous.
Oh, okay, okay. So obstructed umbilical hernia, irrespective of age, we have to operate, and non-obstructed, you can wait for till 4 years.
Yes.
Yes, sir.
So what is the age in inguinal hernia when you would intervene, sir? So is there like a minimum age where we will let the child develop and then you would intervene? So could you just update on the guidelines for us?
If the anesthetic support is good, we should go ahead with the surgery the week it was diagnosed.
Okay, even in a newborn, you have to operate.
Yes, yes,
Yes, yes.
Especially the chances for obstruction and strangulation are more with premature babies.
Oh, okay, okay, okay.
You will have to be extra careful with premature babies that you cannot afford to postpone
Yes, sir.
in the presence of a good anesthetist.
Yes, sir.
Otherwise, the anesthesia itself can become
At
even lethal. You will have to be very careful.
anesthesia and the setup where they can handle pediatric, because infusion IV, IV fluid, you don't normally give IV fluids, but the setup is also very important. They should be tuned to treat these newborn babies. So you can appreciate we are never touched in any inguinal hernia surgery, whether irrespective of open or laparoscopy, we never touch the cord structures.
Coimbatore was a pioneer in pediatric laparoscopic surgery also, thanks to Dr. Kumar.
Yes, sir.
He brought the laparoscopy set into the medical college hospital almost very, very early.
Yes, sir.
And Dr. Rajamani became a very good, nationally leading figure in laparoscopy.
Pediatric laparoscopy.
He is my colleague. Coimbatore.